You may have heard this in passing at an airport or on a travel forum. Don't bring Sudafed to Japan. It sounds like one of those odd, obscure travel rules, a local quirk. But behind that short sentence there is a profound disagreement about how to weigh benefit and risk for a very common drug. Today, I want to explore that disagreement with you, not as a foreign curiosity, but as a practical lesson for anyone over 60 who cares about brain health, safety, and sensible medication use. Imagine a medication you can buy at a neighborhood pharmacy in the United States. Over the counter, behind the counter, or by prescription. Now imagine that same medication in Japan, strictly controlled, treated like a precursor to illegal stimulants and requiring medical paperwork days before you arrive. The medication is pseudoephedrine, a powerful decongestant that sits at the crossroads of respiratory medicine, neuropharmacology, and public policy. Over the next 15 minutes I will explain, step by step, what pseudoephedrine does in the body and the brain, why Japan treats it as a stimulant's raw material, while the United States allows limited consumer access, what the scientific evidence shows about brain and vascular effects that particularly matter to older adults, and what practical choices you and your family should consider when you face nasal congestion or travel to another country. I promise you, clarity. I will speak plainly about the evidence we have and the gaps we still need to fill. Let's begin where most of us start, with symptoms. A stuffy nose, sinus pressure, the relentless annoyance of a cold or allergy season. For many adults, an oral decongestant is the fastest path back to breathing freely. Pseudoephedrine is highly effective for that. Clinically, it works by tightening the blood vessels in the nasal mucosa, reducing swelling and opening the airway. That's its intended benefit. And it works. But drugs produce effects in more places than the label on the box might suggest. Pseudoephedrine is not a purely peripheral drug. It crosses the blood-brain barrier to a meaningful degree. Advanced imaging studies, PET scans that measure how drugs occupy brain transporters, show that pseudoephedrine produces a measurable occupancy of the dopamine transporter. To be specific, in recent research, pseudoephedrine was shown to occupy roughly 18% of dopamine transporter sites, substantially higher than some other decongestants. That number matters because it tells us that pseudoephedrine acts on central nervous system pathways involved in attention, mood, and vascular regulation. Why would dopamine transporter occupancy be relevant to an older adult? Because the dopaminergic and noradrenergic systems help regulate not only alertness, but also cognitive flexibility and cardiovascular tone. For many seniors, the nervous system's buffers are thinner. Age-related changes slow drug clearance. Vascular disease, whether you already have hypertension, diabetes, or atherosclerosis, makes the brain more vulnerable to changes in blood flow. And stimulants, even modest ones, can narrow vessels systemically and in the brain. This brings us to a second mechanism worth noting: vascular effects. The same alpha-adrenergic stimulation that reduces nasal swelling also causes vasoconstriction, narrowing of blood vessels. In the brain, this may reduce cerebral blood flow. Case reports and review-level safety analyses have described vasospasm-like events and associations with ischemic complications. For a person with existing cerebrovascular risk factors, sudden reductions in regional blood flow can, in theory, tip the balance toward an ischemic event. Again, the population most likely to be affected are older adults with comorbidities. So if pseudoephedrine helps breathing but carries central nervous system and vascular effects, how do regulators decide what to do? This is where national philosophies and histories matter. Japan takes a precautionary, tightly controlled stance. The Ministry of Health, Labor and Welfare, MHLW, classifies pseudoephedrine under a category that, in effect, treats it as a stimulant's raw material, the same legal bucket that captures substances used to make and traffic stimulants. Under Japan's regulations, Travelers who intend to bring in controlled medications containing pseudoephedrine must apply in advance for a certificate, typically at least 2 weeks before travel. Domestic access is tightly regulated as well. Some formulations are available only by prescription, under close pharmacy supervision. The Japanese policy aims to prevent diversion and to limit uncontrolled use, but it is also informed by concern about the central nervous system and public safety based on past societal harms linked to stimulants. The United States took a different route. After recognizing that pseudoephedrine can be diverted to illicit methamphetamine production, the U.S. passed the Combat Methamphetamine Epidemic Act in 2005. That law does not ban pseudoephedrine outright. Instead, it moved sales behind the counter, limited the amount any one consumer may buy in a day and in a month, requires photo identification, and obliges pharmacies to keep purchase logs. Prescriptions are exempt from those limits. The approach attempts a pragmatic balance. Keep legitimate access for patients who need it while imposing safeguards that reduce large-scale diversion. Both strategies make sense in their context. One errs on prohibition for the many to prevent harm to the few. The other seeks a compromise that maintains access but monitors use. The question for us, particularly if you are an older adult, is which approach better protects brain health. Let's look at the scientific evidence that informs that question. First, acute effects. Pseudoephedrine reliably raises blood pressure modestly and increases heart rate in susceptible individuals. It can cause insomnia, anxiety, tremor, and rarely, more severe cardiovascular events. Those side effects are well documented and predictable from the drug's pharmacology. Second, subacute and chronic concerns. There are few long-term longitudinal studies that directly tie pseudoephedrine use to dementia or progressive cognitive decline. That is an important caveat. The evidence is limited. However, we do have reasons to be cautious. Studies of stimulant medications generally show that older adults respond differently than younger adults. Medications that increase central catecholamines can sometimes impair cognitive flexibility or worsen underlying vascular issues in older populations. The pattern we see in the literature is consistent. Stimulants can help attention in the short term for some conditions, but their effects on long-term cognitive trajectories, especially in the presence of vascular disease, are not well understood. Third, the imaging and mechanistic data. That PET finding, near 18% dopamine transporter occupancy, suggests a level of central nervous system interaction that is not trivial. Add to that evidence of possible vasoconstriction in cerebral vessels, and you have biologic plausibility for a mechanism by which repeated or high-dose exposure could be harmful in vulnerable brains. What does that mean practically for you, the viewer, over 60? I want to be explicit. Number 1. If you have cardiovascular disease, including hypertension that is not well controlled, atrial fibrillation, prior transient ischemic attacks, or stroke, you should avoid systemic stimulant decongestants unless a clinician insists they are needed and supervises you closely. Small increases in blood pressure or vasospasm can place you at higher short-term risk. Number 2. If you have multiple medications, discuss any new decongestant with your clinician or pharmacist. Polypharmacy is common in older adults, and interactions can alter drug levels or compound side effects. Number 3. If you travel internationally, particularly to countries with strict import rules like Japan, do not assume your U.S. over-the-counter medicine will be acceptable. For medications containing pseudoephedrine, Japan may require advance authorization. Failure to comply can mean confiscation, fines, and even detention. Practical planning matters. Number 4. Consider safer alternatives for chronic or recurrent congestion. Topical nasal therapies, such as saline irrigations or intranasal corticosteroids, provide effective low systemic risk options, especially for chronic rhinitis. Over-the-counter phenylephrine is available in many countries and has less central penetration, but its clinical effectiveness is modest and inconsistent in many trials. Nasal steroid sprays, antihistamines for allergic conditions, and non-pharmacologic practices like humidification can all reduce the need for systemic stimulant decongestants. We must also keep a clear scientific perspective. The Japanese approach is precautionary. It prioritizes population-level protection based on plausible mechanisms and a history of stimulant-related harms. The American approach accepts a regulated availability with tracking. Neither position is necessarily wrong, but they reflect different risk tolerances and cultural attitudes toward paternalism, access, and enforcement. For clinicians and policymakers, the analysis points to areas where more research is urgently required. We need long-term, age-stratified studies that evaluate cognitive outcomes after chronic pseudoephedrine exposure. We need real-world data on older patients who take these medications repeatedly, monitoring for subtle declines in executive function or for vascular events. We also need comparative policy analyses that look at whether strict control reduces harms in measurable ways or simply moves risks into different channels. Until we have those data, my practical advice for older adults is conservative and evidence-aware. Prefer non-systemic therapies for chronic congestion whenever possible. If you must use an oral decongestant, use the lowest effective dose for the shortest possible time. If you have cardiovascular risk factors, avoid stimulant decongestants unless a trusted clinician advises otherwise. When traveling, check the destination country's rules well in advance. For Japan, in particular, allow time for paperwork if you need to bring controlled medications. Talk with your primary care physician or pharmacist about alternatives and about any symptoms, even subtle, that occur after starting a decongestant: sleep disturbance, new anxiety, palpitations, or cognitive fog. Let me close by putting the larger lesson into plain language. Medications are never just targeted tools. They are systemic interventions in complex organisms. What one regulatory system tolerates as acceptable risk, another may decide to control tightly on the basis of plausible biological harm and different social priorities. Japan's decision to classify pseudoephedrine as a stimulant's raw material is not merely an odd legal quirk. It is a policy choice grounded in concern for neurovascular safety and for preventing stimulant diversion. The United States' decision to allow controlled access tries to balance individual need and public safety. For individuals, especially older adults, the practical takeaway is simple. Be cautious, informed, and proactive. If you're over 60 and you or a loved one frequently reach for over-the-counter oral decongestants, please consider this a personal invitation to have a short conversation with your healthcare provider. Ask about non-systemic options. Ask about your cardiovascular risks. Ask whether occasional use is safe for you, and if so, what dose and duration are reasonable. If you're planning travel to Japan, check the official guidance now, not when you're at the airport. Apply for authorization if your medication contains pseudoephedrine and bring documentation. Small steps like these avoid big problems abroad and help protect your health at home. Thank you for joining me in this conversation. If you found this information useful, please like the video. It helps other older adults find accurate, practical guidance. If you or a family member has a story about medication surprises while traveling, or about unexpected side effects from common drugs, share your experience in the comments below. We learn from each other. For viewers who want a deeper dive, I've referenced recent imaging studies, public health regulations, and safety reviews that informed this presentation. Medical practice is always changing as the evidence evolves. My final thought is this: when it comes to medications that affect the brain and the blood vessels, a cautious approach, guided by a clinician and tailored to the individual, is often the wisest approach. Stay curious, stay informed, and take good care of your brain. Breathe easy, but think clearly. See you next time.